Good day, ladies and gentlemen, and welcome to the Freestanding Emergency Department Lessons Learned from the Field webinar. At this time, all participants are in listen-only mode. Later, we'll conduct a question-and-answer session, and instructions will be given at that time. If anyone requires assistance on the call, please press star then zero on your touch-tone telephone. As a reminder, today's call is being recorded. I would now like to turn the conference over to your host, Fred Galfus. Sir, you may begin.
Thank you. Hello, I'm Fred Galfus, a partner in the law firm of Foley and Lardner, and I'd like to welcome you to this web presentation, the Freestanding Emergency Department, Lessons Learned from the Field. We at Foley and Lardner are particularly pleased to be presenting jointly with the Hammes Company. The Hammes Company is a healthcare consulting firm, and it is one of the largest developers in the healthcare field in the United States, and also has an active international healthcare development business. It also offers strategic and planning advice to the healthcare industry. But before we start, I'd like to go over a few housekeeping tips. Our program will last approximately 1 hour. A copy of the slides can be obtained by clicking on the printer icon on the bottom right hand of your live meeting screen. If you have questions, you may type them in the Q&A tab on your screen, and we plan to address them at the end of our presentation. If your questions are not answered, please feel free to reach out to any of the speakers through email or phone contact to address them. Your feedback is greatly appreciated on today's program, so we ask that you take a few minutes and complete the survey that will appear on your screen after the Q&A session. Foley and Lardner will apply for 1 general continuing legal education credit for today's program. Now, without further ado, I'd like to turn it over to Sam Essick of the Hammes Company, who will moderate our panel today. Sam?
Thank you, Fred. Fred, I'm a vice president and partner with the Hammes Company. And during our time today, we will hear from several leading representatives from both Hammes Company and Foley and Lardner. They will offer their perspectives on the benefits and challenges of freestanding EDs, including strategic, regulatory, and design issues. Our presenters will provide you with a better understanding of the major components within a freestanding ED, plus information about its role in your ambulatory strategy. They'll also present 2 case studies. The first will provide a decision framework for evaluating freestanding ED strategies, and the second will identify the features and benefits of freestanding ED prototyping. Now let me introduce you to our presenters. Fred Galfus is a partner with Foley and Lardner and is a member of the firm's healthcare industry team. Fred is co-chair of the Healthcare Industry Team Business and Transaction Work Group, where he counsels health systems, hospitals, medical clinics, rehab agencies, nursing homes, and other healthcare providers on general operational concerns and both regulatory and business matters. He has many years of experience in healthcare acquisitions, integrated delivery service issues, managed care contracting, defense of providers against government enforcement actions, finance, real estate, physician recruitment, fraud and abuse matters, and other health law issues. Eric Lardner is a vice president and partner in charge of Hammes Company's Seattle office. His primary responsibilities include managing efforts in the delivery of a wide range of projects with a concentration on planning and ambulatory care center development. Mr. Lardner has over 35 years of experience in planning, design, and development, focusing exclusively on the healthcare facilities for the past 15 years. Prior to joining Hammes Company, he served as Director of Facility Planning and Design at a major tertiary care center. Sam Sears is a senior planner with Hammes Company. His primary responsibilities include developing strategic and financial business plans and feasibility studies, ambulatory network plans, strategic facility and operations plans, and other strategic planning engagements. Previously, Sam was a senior consultant for a national consulting firm which offers advisory services exclusively to the healthcare industry. He also served as a director of clinical research for cardiac surgery at one of the largest healthcare providers in Massachusetts. Now I'll turn it over to Sam Sears.
Thank you, Sam. I'm going to really kick off the content of this with an overview of freestanding EDs. What's happening out there in the market? What are the trends? what do these things look like? So I think we're all aware of the industry focus these days concerning ACOs. I think what we're really seeing is, for the most part, a wait-and-see approach. I think some healthcare systems are more proactive than others. Some are really just dipping their toes in it right now, but I think the majority are kind of waiting to see how that plays out. I think nonetheless, though, hospital systems still need to execute the elements of ambulatory care center, especially with a focus on off-campus outpatient services and creating linkages across the continuum of care. We've all heard for many years now really about outpatient shift, that hospital systems can't survive alone anymore on just a focus on inpatient volume. So I think that outmigration of care is really both a threat and an opportunity for hospital systems. I think it's a threat because it's very challenging for hospitals to operate and run outpatient centers, especially off campus. Now, some do it better than others, but it's really not a core competency, especially when you've been inpatient focused for so long. And the competition really is very outpatient focused, and in many ways can do that more efficiently and at a lower cost than hospitals can do that. But really part of the challenge is these outpatient centers can't be operated like a hospital department. But it's also a huge opportunity for hospital systems, and they have some advantages that more traditional outpatient providers don't have. They have larger available resources to get into this, and they can leverage their brand name out in the market. We've seen access to care continue to decrease. A lot of emergency departments have been closing across the country, and this is coupled with emergency departments visits increasing across the country. This has resulted in longer wait times and patients really looking for other ED options. A lot of these capacity issues have not been addressed on the inpatient side, so there have been alternatives. And I think really the growing expectations from patients these days are really driving a fundamental transformation in the delivery of emergency care. So the focus of this really then is the freestanding ED as a solution to this issue. Freestanding EDs, they provide a lot that a hospital ED cannot. Convenience. You don't really have to deal with all the hassles involved with going to a hospital ED. They're more likely to be in an accessible location. So, for example, typically freestanding EDs are more in a suburban location than, say, an urban location. And they've really been becoming more prevalent out there. So I think you've seen the proliferation of freestanding EDs across the country. And in some areas, the activity is really huge, say in Virginia, Ohio, Texas, Washington State, and others. Other states are really just getting into this now. I think you see that in New York and New Jersey. A couple of new ones. Actually, in New York, I don't think there's any open now, but a couple are in development. New Jersey, a new one just opened recently. Even in Florida, where the governor actually, they started in the mid-'90s. The governor put a moratorium on them, lifted them about 2 years ago, and since then you've started to see those really spreading out in the market quite a bit. Mount Sinai is a good example of a hospital that was actually denied a CON for a hospital in their state and then went the freestanding route instead. Now, freestanding EDs are not without their critics. There's concern that they're skimming off patients. I think some of this, I think there was a lot of this in the beginning. I think this is lessening somewhat as a lot of hospitals have sort of realized if you can't beat them, join them. But I think that criticism is still out there. So why would you do a freestanding ED? This pie chart really shows the variety of reasons, and it's not always one reason. Most of these elements contribute to why they might do it. Number one is capacity issues on campus and going around market entry strategy where you really establish your presence and increase your brand awareness in the market. Also a market penetration move where you're really trying to get into a market and increase your market share. Response to competitor moves. It's a little bit of a Me Too strategy, but I think they've seen the success in the market, and so they're trying to replicate that success. It's a more efficient operating model. You can operate these obviously at a lower cost, less bottleneck issues at a freestanding ED than you have to deal with at a hospital. For example, you don't have to deal with bed placement, which often ends up clogging the ED. Convenience, we've talked about, convenience and access. It also can help them increase physician referrals A freestanding ED really ties the institution into its physician network and into patients in the network. And of course, the financial benefits of increasing downstream revenues. These are all reasons why we've seen these really take off in the last few years. So, if you think about urgent care centers versus freestanding EDs, really how are they different? And I think they are fundamentally different. Urgent care centers are low acuity, low cost. I don't think they're viewed by patients as a substitution for an emergency department, whereas I think a freestanding ED is viewed as a viable alternative to going to a hospital ED. You get a comprehensive solution, and I think there's really a higher level of patient comfort that these freestanding EDs can really treat all but the highest acuity patients. And I think that level of comfort, frankly, doesn't really exist at urgent care centers. Compared to freestanding EDs, urgent care centers are of course, low cost, more minimal staffing, and really they operate more similar to a primary care practice than a hospital, where a freestanding ED is a little bit more like a hospital, although different in many key ways. Urgent care centers, I think, are often more of a physician strategy, whereas freestanding EDs, again, tend to be a more broader and deeper and a larger breadth strategy into a market, and really across services, enhancing physician relationships, not just in primary care. Compared to freestanding EDs, the reimbursement's lower. Clearly, I think what we've seen is that it's really a tougher nut to crack in terms of operating a freestanding ED from a pro forma perspective. A lot of hospitals, I think, have had a lot of difficulty in making urgent care centers work. The independent providers out there who do that as their only business really do it a lot better, I think, than hospital systems do. They're not accredited the same. They're not open as long. They really are quite different. Typically, freestanding EDs are located within 20 miles of a parent hospital. I'd say that for the most part, the majority of them are 5 to 10 miles. Some are certainly longer. I've even seen a handful closer than that, but that's the kind of typical range. And often they serve as an anchor to a larger ambulatory facility, similar to an MOB is often attached, where you have a variety of primary care and multi-specialty practices. General characteristics of a freestanding ED. In terms of socioeconomic factors, they really are more attractive to younger populations. If you think about the sort of transformation of healthcare, where in the past people had long-term relationships with their primary care physicians, I don't think you're seeing that today, especially with people in their 30s and 40s. They just don't establish those long-term primary care relationships. So I think in that kind of an environment, a freestanding ED is much more attractive and much more likely to succeed. Now, you often put these in target markets with a desirable payer mix. I talked about you tend to see them more in the suburban areas than urban areas, so that's part of it. It's often part of a overall system strategy to grow their presence in key growth markets. In terms of payment methods, and Fred's going to get into this a little bit later, but freestanding EDs typically are licensed as a department of the hospital, and this is for the better reimbursement rate. However, one comment here is I think private insurers are starting to push back on that, so you will get the better Medicare rate. However, I think private insurers are starting to push back a little and impose lower reimbursement rates than they do at the hospital ED rates. I think that's very much a negotiation between the hospital and the payers, but I've seen it as low as 50%. Typically, it's more in the 70 to 80%, but right now most of them still do get the full reimbursement level. It is more efficient than a hospital. They are open 24/7. It's really a different layout, too. You don't have big waiting rooms. Often they take the patients straight to the bed for triage. Typically about 4 to 10% of patients are transferred to an acute care setting compared to an urgent care center of about 2 to 3%. So I think when they started to open, and I've seen some actually with more than 10%, so I think a little bit more downstream even than people originally anticipated. They often include a full range of advanced imaging capabilities, clinical labs. Some even have short-stay observation beds. Typically, CT and X-ray are the diagnostics you see there. Often you'll have rehab services, other ancillary services. Often they're part of a larger healthplex, that attached MOB that I mentioned. And they can be located in B occupancy facilities. So compared to a hospital, you can significantly reduce capital expenditure costs for that reason. Critical success factors are being in a high growth market. When do these typically succeed? They exceed in those growth markets. When they hit 12 to 15,000 visits, I've seen some work with less, but I use that as a general rule of thumb. First to market is a key strategy, but it's not the only one. I don't think a freestanding ED boxes out other systems from potentially putting them up, but clearly getting in first, getting to the market first, I think is really a big success factor. Strong coordination with local EMS providers. Outreach to EMS is a key part of this. Getting them on board, getting them to deliver patients to your facility is very important. So you really need to start that before the hospital, before the freestanding ED opens. Also, no to minimal wait time. That's obviously one of the key attractiveness factors of freestanding EDs. So that needs to be implemented. Patients really have, I think, higher expectations for a freestanding ED than an emergency department. I think when they go to a hospital emergency department, they realize they're in for a long wait. Parking's going to be tough. It's not an enticing environment to have to go to. And I think with freestanding EDs, the patient expectations are really much higher. They expect quick turnaround times. They expect more of a customer service model. And again, these don't exist in a vacuum. Obviously, MOBs and other support services go hand in hand with a freestanding ED, although some are strictly just freestanding EDs. So what are some of the challenges? A little backlash in terms of cherry-picking patients. There's always concern about cannibalization, especially in a high market share area where you're placing a freestanding ED. I think typically that's actually been the experience is generally lower than people anticipate. Significant outreach efforts are needed. We've talked about that. Having the right operating protocols. And while they may not be able to handle the most critically ill patients, I think for the most part people are often surprised just by how many high acuity level patients they do take. And capital and land requirements are much greater than just a smaller outpatient facility for freestanding EDs. Fred's going to get into a little bit of the regulatory, but suffice to say it varies by state in terms of CON restrictions. Some states are not even allowed, like in California. Benefits of a freestanding ED: better penetration, downstream volume, higher patient satisfaction, more efficiency and throughput. One thing we haven't really talked about is the profitability. I think what we've seen, though, is that the operating or the pro forma profile for these are very attractive. I think to date so far, the ROI has been very strong on freestanding EDs. We talked a little bit about this before, the lower capital costs and your ability to utilize third-party financing are additional benefits of a freestanding ED. So at this point, now that we've taken a look at what they are, I think the next question is a freestanding ED right for a hospital system? So I think this is kind of the checklist of questions that you have to go over to answer that. Can your market support it? How is the market being served right now in terms of emergency services and even urgent care services who might compete with that? What impact will the expected healthcare environment have on a freestanding ED? And I talked a little bit about those reimbursement challenges, and I think that's one of them that we may see change a little bit. Does your hospital have the capabilities to execute a freestanding ED strategy in their market right now? What will it look like in terms of scope of sizes? I think we see a scope of services and sizing of a facility. I think we see a wide range of what these look like. And finally, if it is feasible, what are the next steps that you need to do to move towards an implementation strategy and plan? So what's involved in a freestanding ED business plan? You can see the elements here. You typically have to start with a market assessment, understanding what the potential volume capture is, understanding the physicians in that market, understanding how you're positioned vis-a-vis your competitors. Are they doing these in the market? How might they actually respond to this? Typically, we actually see ED use rates go up when a freestanding ED is introduced to a market. I think what that says is that a lot of patients who were forsaking care because they didn't want to go to a hospital ED or using their primary care physician, waiting that out, now see this as a viable alternative. And because of that, I think you've seen some actually impact on use rates in the market when these are first introduced to a market. Obviously, you need to do very detailed volume projections, and finally a site and facility assessment to make sure that these are going to work. So with that, I'm going to turn it over to Fred.
Thank you, Sam. Freestanding EDs are getting a lot of current attention, but actually the first freestanding EDs were developed in the 1960s. As of the year 2008, it was reported that there were 222 freestanding EDs open in 16 states. At that time, approximately two-thirds of the states had not yet developed any freestanding EDs. 191 out of 228 were reported to be hospital-affiliated. And it must have been after the 222 freestanding EDs, a little bit after that. And 70% of them are open on a 24/7 basis. The rest have more like urgent care hours. The services that we see offered, as Sam talked about, it's more than urgent care, but it's really not a full-scale ED with the backup of a full-service hospital on the same campus at the same location. You'll frequently find defibrillations and intubations provided. You'll have ER care as well as urgent care provided. Lab services will provide for rapid tests. Radiology procedures, we've seen X-ray, CT, and ultrasound usually available. And they are staffed by board-certified emergency medical physicians and qualified nurses, which is one of the advantages. Also, we've seen a number of them that offer 911 transports. We've seen combinations with observation beds. Many will have a helipad, and oftentimes they're centered on a campus that also includes a medical office building, an imaging center, and a surgery center all at the same site. I found this information of interest. The Center for Disease Control and Prevention estimates on the acuity that are seen in typical EDs. This data is not for freestanding EDs. But you'll see the statistics there. 15.6% really need immediate or emergent care. And we can expect that for freestanding EDs, there will be a self-selection process, and the percentage of immediate and emergent care seen in freestanding EDs will be no doubt less than the 15.6%. I think Sam suggested a 10%, as high as 10%, and that may well be the case. But few EMS systems do 911 transports to freestanding EDs at this point. And the feds also report that 5% of the visits result in inpatient admissions, while the average hospital admission rate is 12.14%. So the acuity level of those treated at a freestanding ED is presumably somewhat less than the hospital campus EDs that we've seen. But let's talk about the regulations. There are both federal and state regulations to be concerned with. Here we have a federal regulatory definition of an emergency department, and this comes from the EMTALA statute, the anti-dumping statute. You'll see that it defines it that it's regardless of whether it is located on or off the main hospital campus, and it has to meet one of the following requirements. Licensed by the state as an ED, held out to the public that provides care for emergency medical conditions on an urgent basis without an appointment, or if during the course of the year it provides at least 1/3 of all outpatient visits for the treatment of emergency medical conditions without a scheduled appointment. Freestanding EDs, as Sam mentioned, are frequently and most commonly put together as provider-based operations of a hospital. And we'll talk about those provider-based obligations, what they are. And within as provider-based operations of hospital, they can be classified as a Type A dedicated ED or a Type B dedicated ED. We also have seen those that are not hospital affiliated, but they're operated as an outpatient clinic and may not be owned or controlled by the hospital and are not viewed as hospital or provider-based. The level of acuity or the type of hospital, the type of your organizational structure will also define your reimbursement. In a Type A dedicated ED typically is hospital-based. It operates under the same provider number as the main campus hospital. It is open 24/7, and it has EMTALA obligations. A Type B dedicated emergency department, the biggest difference is it's not open 24/7. It still has EMTALA obligations, and it still is provider-based. It's been reported that the Type A reimbursement is likely to be 25 to as much as 100% more revenue per visit than the Type B reimbursement. And the Type B reimbursement is higher than the outpatient clinic reimbursement. And clearly this just makes sense. If you're open 24/7, you're incurring the cost of a hospital. You're going to have a higher cost structure, and therefore that will lead to higher reimbursement. And Type B is kind of an intermediate. It's hospital-based, not open 24/7, so not incurring the same level of cost and lower reimbursement. And the clinic operated or outpatient clinic reimbursement is even less because it's not operated as a hospital, doesn't meet life and safety requirements of a hospital. Most of you are no doubt aware of the conditions for off-campus departments to be provider-based. They're recorded at 42 CFR 413.65. They operate off-campus departments that are provider-based operate under the same license. They have integrated clinical services. They are financially integrated with the hospital. The public awareness, there has to be public awareness signage and forms that reflect that it's part of the hospital under the same, operating under a similar name, same name. And it has to meet the obligations of the hospital outpatient departments. There's also a requirement that it be proximate to the hospital. There's a 35-mile requirement, but there's also an alternative test. In addition to these, they share a medical staff with the main campus hospital. The same monitoring of their services. The medical director of the freestanding off-campus emergency department reports similarly to a department medical director, and we have an integrated medical record with the main campus of the hospital. The EMTALA, the anti-dumping statutes also will apply to freestanding emergency departments that are operated by a hospital. This means that you will need to, for every patient, do a medical screening examination within the capability of the emergency department. It needs to be performed before you ask about payer source. You need to provide stabilizing treatment to those with an emergency medical condition or an active labor, or provide for an appropriate transfer. And you have to treat within the capability of the facility before you arrange for the transfer. The government will likely consider the capabilities and capacities of the main campus, and that's a bit of an issue as to how much care do you need to bring to the freestanding ED. It's a little bit of an open issue. Another regulatory requirement that will apply to freestanding EDs that are operated as part of a hospital is the so-called 72-hour rule. Under the 72-hour rule, generally there is a requirement to bundle the services that are provided on the day of or within 72 hours of an inpatient admission with the inpatient admission. So diagnostic services performed on the day of or within 72 hours of the inpatient admission are bundled into the inpatient bill, and for Medicare, the DRG, so they're not separately payable. So if you go enter enter the hospital through a freestanding emergency department, those diagnostic services likely are going to be included in the DRG and not separately reimbursed. Non-diagnostic services performed within the 72 hours have to relate to the admission. If they relate to the admission, are also bundled. This has been a big compliance issue for hospitals for a number of years to be able to track and properly handle these, but it's an important issue to be aware of. We also have to worry about conditions of participation, and they are reported at 42 CFR 4255. These are requirements to participate in the Medicare program, and your freestanding ED will need to meet them. They have to be, your services will need to be organized under the direction of a qualified member of the medical staff. The services integrated with other hospital departments. The policies and procedures and ongoing responsibilities of the medical staff will be similar. They have to be services supervised by a member of the medical staff. And you have to have adequate medical staff and nursing personnel to meet the emergencies. They're also accredited the same way as the hospital, frequently by the Joint Commission. It should also be noted that if you offer anesthesia or respiratory services, those services must also meet the specific conditions of participation that apply to them independently. Let's talk about the state regulation, and it is the states that regulate freestanding EDs. And we really, at this point, are seeing four categories. We have some states that are specifically regulating and licensing freestanding emergency departments. Examples are Texas, Illinois, and Delaware. Some states have specifically analyzed it and determined that their current licensure covers freestanding emergency departments, and particularly on the outpatient clinics, they license them as outpatient facilities. And Florida is an example of that. Some states are silent on freestanding emergency departments. Wisconsin's an example of that. If it's part of the hospital, then it likely needs to be licensed as part of the hospital, and you will need a variance if it's off campus. If it's physician-owned or just operated as an outpatient facility, there is no specific license requirement in Wisconsin. And in California, again, they haven't addressed them specifically, but the existing definitions of hospital licensure actually are deemed to preclude freestanding EDs at this point in California. Here's an example of what the Illinois requirements are to obtain a freestanding emergency department license. You have to be in a municipality of less than 75,000, 20 miles from a hospital, from the main campus hospital. And then you must meet a variety of other requirements: facility design, equipment standards, personnel standards. Here's some more. EMS system participation must be limited according to protocols. It has to be comprehensive emergency services. There have to be ambulance services on site. There's a requirement to report on patient transfers and to submit mortality and morbidity reports to the state. And you cannot hold yourself out as a providing full service hospital services. Texas is probably the place where there are the most freestanding emergency departments, and they also license them separately. Currently, the licensure does not require 24/7 operation, but as you can see here, they will be required to be open 24/7 by August 31st of 2013. In Texas, similarly to Illinois, they regulate the construction and design, the staffing, the administration, the equipment, the medical records, patient transfer policy, the services that are available, and the medical staff regulations. In California, they've treated them differently. There is no explicit treatment of freestanding emergency departments, but their typical hospital statutes and codes provide for use of the term emergency, from limits on the use of the term emergency or emergency medical services. And by definition in California, a facility using the term emergency and holding itself out as providing emergency medical services must effectively offer a variety of other services that essentially means it's a full-fledged hospital. Also, emergency department must be licensed to provide emergency medical services, so it must be in a hospital. There's a limited exception for urgent/emergent care facilities operated in rural areas. If you can get the local EMS to grant approval, these are largely urgent care operations. You can't advertise as an emergency center. You can't be open 24/7. You bill them as an outpatient service. There has been some legislative activity in California over the last several years, but to date, nothing has passed to permit freestanding emergency department. Another issue that you need to worry about is the certificate of needs, and this is a state-by-state regulation. Wisconsin currently doesn't have a certificate of need statute, and Illinois has a very tough one. But commonly regulated activities would be the establishment of a new facility, the renovation of a new facility, particularly over a particular dollar threshold, the purchase of major medical equipment over a dollar limit, some regulate changes in ownership, and at times it needs to be by or on behalf of a hospital. Finally, some other issues that you'll want to consider as you develop a freestanding emergency department will be to talk through the EMS protocols, make sure there's proper communication and collaboration with the EMS system. You're going to want to have a transfer policy. You're going to want to be sure that if you get the very sick patient that needs to be transferred to a hospital, that the nearest hospital will accept it without question. You're also going to want to arrange for call arrangements to provide effective service. You may want to have an orthopod or an eye surgeon or a trauma surgeon quickly available. The services offered probably will be more limited than a hospital on-campus emergency department. And I think one thing you're really going to want to consider is what do you co-locate with the freestanding emergency department? Does it make sense to have an MOB or an ASC at the same location? So with that, I'm going to turn it back to Sam Sears and talk about some case studies. Sam?
Thanks, Fred. First case study is a freestanding ED in Virginia, so I want to just get into the details of that a little bit. It opened in 2007. It was part of a market expansion strategy to penetrate markets off of a hospital campus. They actually already had an MOB and an ASC when they decided to build the structure for the freestanding ED. So they did have a little bit of a presence in place. Their competitor actually has multiple freestanding EDs in the larger regional market, although not in this specific area. Interestingly, when they did open their freestanding ED, that competitor actually came right in and opened one less than a mile away just 2 years after that. They actually built this freestanding ED as part of there's a larger strategy to potentially transition it into a hospital in the future, essentially replacing one of their struggling hospitals. I don't think they're there yet, but I think that is a tactic that you've seen or a strategy that you've seen with some hospitals. I think Wake Med is a good example of a freestanding ED that did very well, that transitioned into a hospital. There's one in Boardman, Ohio, where they did the exact same thing, and that one's interesting also because they opened another freestanding ED in that market, but without the notion that they would eventually transfer that into a hospital. So they've sort of executed both sides of that strategy and been very successful with it. So this freestanding ED in Virginia really has thrived quite a bit since this opened. Despite the proximity of some hospitals nearby, there's 2 hospitals within a 10-mile radius, it's done so well that they actually opened a new MOB across the street just in 2010. So what kind of market is this? It's got a population of about 130 million. Typically, we define the markets for freestanding ED as about a 15-minute drive time. I think that might vary depending on whether it's a rural area in which you would have a longer drive time versus an urban area. The geographic area is approximately 13 by 11 miles. By that, I mean really the capture area for that population. It is a good growth area, 6%. I know some markets are better, some are worse, but in this particular market, it was a little bit. It had a higher growth profile than some of the other zip codes in that area. It was a suburban area, But off to one side, if you think about the density of population being in the center and thinning out as you move outwards, this was kind of on the periphery of the market. We're a pretty good suburban population, but then as you move outwards, it gets rural pretty quick. It was a half mile from a major interstate highway, good visibility, good access, and I think really that's another commonality among freestanding EDs is near highway intersections or near high visibility access points. Just in terms of some other logistics about it, the closest hospital in the system was 6 miles away. There was then that freestanding ED that opened just a mile across, practically across the street, and the closest competitor hospital was 9 miles away. If you look at the volume, they did transfer about 5% of their volumes for admission, and Fred discussed that number, so that one's right on the average. I think when you see those higher ones, and that is less common, but typically if it's going to approach the 10% number, those tend to be in areas that don't have good hospital access when you hit that higher. So they're really treating most of the patients in a given area. Typically 1 out of 3 visits has an X-ray and 1 out of 8 has a CT, which is why those are the 2 most common imaging modalities that you see in freestanding EDs. This hospital had or this hospital system had a pretty strong market share in this area at 60%. I think when they did that, and half of the ED visit volume at the hospital came from this what we would call the primary service area or capture area for this freestanding ED. So I think there was some concern about cannibalization, definitely some risk involved with this project, but a lot of that actually didn't come to fruition, and I'll talk about that in a second. In terms of the freestanding ED visits at this new site that came from that capture area, about 70%. So 30% came out of the market. And it was interesting because some of that is the more rural secondary that I talked about, but really some of the urban population or on the sort of urban-suburban line actually traveled in the opposite direction to go to a freestanding ED because of the convenience of it. So I think that was pretty telling about how successful these can be. It was a 100,000 square foot facility. Only 11,000 of that is for the ED, and it's on 2 floors. The ED itself is only on 1 floor, where the imaging modalities were centered between the physician-based services and the freestanding ED, so they can both access it, but at different access points. Had 17 ED rooms or beds, included 6 monitor beds, 3 fast track, and 4 specialty rooms. When they build it, they did attach it to the other buildings, so there is access from there. And again, it's they just added a new MOB across the street. So it costs about $5 million to build. This is in 2007 dollars. One of the challenges, and I talked about this a little before, was getting the EMS traffic to the building. That took a lot of outreach, a lot of effort, a lot of educational lunches and dinners to get the EMS traffic to the site, but they eventually succeeded. You can see the other services in the building as well. Look at some of the data. You can see a couple of things here. There's both annual and the first 10 months of opening ED visits. You can see a pretty quick ramp-up period, really month by month, pretty aggressive growth. They actually did not open this 24-hour, and I think that was more common a few years ago. I think it's more rare today to have freestanding EDs not operate 24 hours, even right out of the gate. And I think if you ask them, if they said, you know, if one of the lessons learned, if they were to do this over again, and the system has done other freestanding EDs, they would open right off the bat at 24 hours. You can see when they went 24-hour, the volume sort of, which had a slower growth for a while, then took off and went from 1,600 to 2,400 in just a few months. You can also see, if you look at it on an annual basis, and they're up to over 25,000 visits, you see that quick growth from the first month, the first year, which is annualized data based on 6 months, and then you look at FY08, rapid growth in the second year, and then it was right after that second freestanding ED opened just across, just nearby. And the volume really didn't suffer too much. It leveled off somewhat, obviously not the same growth, profile. But when they budgeted for that, they actually expected to have much more severe volume losses, and frankly, that never really materialized. This is really sort of two slides. You're going to see some acuity information on the next page, but we took a look at the acuity mix. So people often wonder, you know, just what is the patient population like from an acuity perspective, hospital. So we compared it with the freestanding ED to the hospital. We used the emergency severity index, which for those familiar is actually a little bit different than the standard emergency acuity index that hospitals use. This is actually a coding system used for triage, and this is how they evaluate the population. What's a little confusing and perhaps frustrating for planners is it flips it. So they're both 5 levels, but at this one, the level 1 is the highest, with the other one, level 5 is the highest. This data actually, as you'll see on the next page, it excludes left without being seen patients, which is actually a pretty small proportion of it. So if you look at the 2 pie charts here, again, with the 1 to 2 ESI level being the highest, not surprisingly, you have the hospital as 24% of the patients fall into that category. For freestanding ED, only 4%. Really less than 1% are at that highest acuity level. And then when you get into that sort of mid-level, ESI level 3, you can see the proportions pretty much the same at the 2 hospitals. And then, and somewhat surprisingly, at the lowest acuity level, the hospital actually had more patients than the freestanding ED. I think some of that was a function of its location. But you can see that the level 4, so the second lowest acuity level, you know, really is the sweet spot for a freestanding ED. In terms of financial performance, it's been very successful. Operating income here 10%, which I'm sure many of you are familiar with operating margins at hospital, which aren't nearly that robust. And that does not include any downstream revenue. They had about 1,300 admissions come out of the freestanding ED that were transferred to the hospital. So that's obviously a benefit as well. Some of the lessons learned, they consistently came in over budget. They really hit their numbers, their sort of mature 4-year numbers really in a year. And their budget numbers were often exceeded by more than 50%. That first-to-market strategy was key, and I think it really secured them in the market so that when that other one opened, it really, the impact of that was less than expected. Even the cannibalization, I think, was much less than expected. They've estimated that at 5%. And if you think the fact that 50% of the hospital's patients came from this area, I think that was a bit of a surprise for them. And it's been so successful for them that they have just opened a new freestanding ED, quite a bit distance from that one, but they just opened it in November of last year. Some of the other other lessons learned, rather, patient awareness, aggressive marketing, creating that retail mindset for delivery, I think is key. You need a seen in 30-minute or less guarantee, and some even do 15 minutes. I think those are important keys to success. I think your staff has to be aware that patient expectations are high for this, and that does lead to high patient physician satisfaction. And I think in some ways this was a challenge. I don't think they start out this way, but I think that they get to that pretty quickly. Physician support from the community was key for this to flourish, and I think it really was a key strategy for this system. In some ways, their main hospitals were struggling. It really gave them an outlet, a revenue stream that I think exceeded their expectation. It has led to other freestanding EDs for the system. And I think overall they definitely consider the endeavor to be a real win for them. And now I'm going to turn it over to Eric for a case study on prototyping.
Thank you, Sam. I want to be cognizant of everyone's time here, so I may run through these slides a little more rapidly than I had planned. But once the decision is made to develop one or more freestanding EDs, the speed to market issue often drives and shapes facility design design, and the construction processes. The strategic imperative associated with that decision frequently entails bringing multiple freestanding EDs online within a short time frame. And that was our experience recently with a healthcare system in the Pacific Northwest. At the time the healthcare system decided to develop a freestanding ED network, the state legislature was under increasing pressure from competitors to implement a moratorium on freestanding EDs and initiate a study of their potential impact on the quality and cost of healthcare delivery. Those same competitors were, of course, simultaneously preparing their own plans for developing freestanding EDs. And while the moratorium idea has been rejected by the legislature more than once, the controversy is expected to continue, increasing the pressure to develop facilities as quickly as possible. So in that context, creating a prototype facility was really the only practical way to rapidly open multiple new facilities. The prototyping process, in this case, started with a highly successful patient care model, which the healthcare system initiated when it opened the state's first freestanding ED 3 years earlier in a renovated commercial building. It's not clear whether they had visions of a freestanding ED network at that time. I think they were dipping their toe in the water, and they were first to do that. So they had the advantage of knowing what worked and what didn't. Initially, we targeted two communities, both located in growing suburban areas that were medically underserved and relatively close to the system's existing hospitals. As the healthcare system's selected developer, we secured properties with high visibility and good access to major traffic arteries, and with the fewest zoning and regulatory challenges. Almost immediately, competitors launched their own efforts, both to stop this healthcare provider's efforts and also to initiate their own at local, county, and state levels. The hallmarks of the provider's proven patient care delivery model are many of the ones that Sam has mentioned already. They're built around a no-waiting process that bypasses traditional triage and registration functions. The patient is immediately brought to an exam room where clerical and clinical encounters are stacked rather than provided sequentially. Since the two facilities opened in late 2010 and 2011, respectively, average throughput times under 85 minutes have been maintained at both facilities, and that was an improvement upon the original patient care delivery model made through incremental changes in that model. Both facilities are staffed with board-certified physicians, RNs, and support personnel who are trained and experienced in emergency care. Both facilities have 3 equally sized floors and total roughly 85,000 square feet. The first floor of each contains the ED and imaging functions. In one of the facilities, the lab is also located on the first floor, immediately adjacent to the ED. And in the second facility, the lab was placed on the second floor to allow the ED to accommodate 6 observation beds. The other 18 beds in the ED include 1 for psych patients and 2 connected trauma resuscitation rooms. The upper 2 levels contain physician offices and market-specific outpatient services. Those include physical therapy, cardiac diagnostics, and a sleep center. One of the buildings, and I should say both buildings, were built to meet occupancy standards. And so in one of them, we wanted to provide for the potential in the future for an ambulatory surgery center. And so we applied some fireproofing to the structure of below the 3rd floor to allow an ASC to be generated in the future on the 3rd floor. The resulting prototype has a simple rectangular footprint that's cost-effective to build, and that allowed its modest construction budget to accommodate some high-quality finishes and fixtures. Building plan and overall dimensions were derived from both the ED workflow and patient care model, and also from a structural base size that's optimal for a variety of healthcare uses. By placing the stairs and elevators at the building's outside corners, higher layout efficiencies were achieved and a flexibility of use was maximized. There are 3 separate and clearly marked entrance canopies and vestibules, one for the ED, one for diagnostic, imaging, and medical offices near the elevators, and a third for ambulances. The design and construction team was brought together during the early stages of design to identify and refine the most advantageous construction methods and building envelope. Employing a system of tilt-up concrete wall panels allowed us to shorten the construction schedule by more than 2 months. Because the concrete panels were designed as load-bearing elements, we were able to eliminate most perimeter steel columns. And the panels were also configured, reinforced, and thickened to incorporate all seismic and structural shear requirements, which eliminated the need for any interior bracing. The inherent economies of tilt-up concrete allowed our budget to dress up the panels with brick veneer on the first floor level and other aesthetic details on the upper portions of the panels. Those same economies enabled us to afford creative solutions for managing stormwater and enhancing the site's landscaping features. The most significant of these is a kind of a spine of rain garden plantings that runs the entire length of the building and helps integrate the building with the site. In the Pacific Northwest, green or low-impact development features like these are increasingly expected. So naturally, they tend to drive up site costs and require correspondingly lower building costs in order to maintain market-based rents. The benefits of using tilt-up construction were significant in terms of both budget and schedule. I should say, we went out to bid on these projects in 2009, so to some extent we benefited from the financial implications of late 2008, and were able to take advantage of the significantly lower pricing primarily for labor. But the cores and shells of both buildings were completed in under 8 months, roughly 2/3 of the 12 months required for more traditional construction methods. Shortening the schedule both reduced general conditions costs and brought both buildings online well ahead of the competition. Cores and shells of both buildings cost less than $90 per square foot, which is also roughly 2/3 of the $135 per square foot, which we estimated for similar benchmark facilities. As I noted earlier, that's allowed us to include higher grade finishes and details in the project, but it also lowered rental rates that improved the healthcare provider's operational bottom line. Benefits of prototyping freestanding EDs should extend to future facilities as well. The design and documentation process for additional buildings can be shortened to only 2 or 3 months, which would provide sufficient time to deal with site and regulatory requirements and accommodate incremental design improvements. The prototype's efficient building layout is beneficial to both landlord and tenants because it maximizes the amount of usable square footage within the building's footprint while minimizing the amount of common area square footage. Our prototype achieved very high efficiency ratios, 88% usable to gross square footage and 95% rentable to gross square footage. In anticipation of opening the 2 new facilities, the healthcare system trained ED staff at its original freestanding ED. It found that being able to train staff in nearly identical work environments improved the effectiveness and increased the speed of that training. That in turn reduced labor costs as the facilities ramped up to receive their first patients. Lastly, these 2 first prototypes have established a high-quality brand identity that's clearly identifiable and will only be strengthened as additional facilities are developed. At this point, I'd like to return to Sam Essick to lead us through some of your questions.
And if you have additional questions that you'd like to submit, you can do that on the upper left hand of your screen. The first question we have I'm going to address to Fred Galfus. Does EMTALA still apply if a facility is not hospital affiliated?
The EMTALA statute applies to hospitals, and it wouldn't apply to a clinic-operated facility. They do define hospitals to include critical access hospitals, which you may know are not typically always aligned exactly with the definition of a hospital in the Medicare regulations. But the EMTALA regulations are limited to hospitals.
The next question is for Sam Sears. How was the cannibalization rate calculated for the study, for the case study?
That's a good question. It was estimated based on the client's information. So I think there's a level of certainty that's probably not achievable with that data. But I think what they did was they looked at their trends on a zip code level, and were basically that's where that number came from. So if you look at the zip code volume coming in and how that changed at both the new place and the old hospital, that's where that number came from.
The next question I'll address to Fred. Are there any benefits to partnering or outsourcing the operations of this similar to a surgical center?
There can be some drawbacks as well. If you want to be hospital-based and you joint venture off the hospital campus, there are some real limits on ability to do that. Obviously, there are benefits if you can get around that regulatory issue, but I think the regulatory issue may say that you can't have a provider-based facility off campus and that's a joint venture in the typical situation.
Okay, well, I know we've gone over our time a little bit here, and I think we've got through most of the questions that have come through. So at this point, I'm going to conclude the webinar, and thank you all for your participation.
Ladies and gentlemen, this concludes today's conference. Thank you for your participation and have a wonderful day. Speakers, please hold on the line.